I'm talking to you about something that's really a little bit more philosophical than is commonly talked about at these kinds of conferences. Thank you for coming. I hope you'll find it interesting. It's going a little faster than I would like. I wonder if I can hit the back button. Here we go, back button. So I'll talk about problems of living, about diagnosis, etiology, causes, and treatment. I'll talk about a little bit about our paradigm shifts in mental health, and then I'll make some brief recommendations. So these pictures are from my home country in South Africa. They're a little bit political, and I didn't want to make political comments about Turkey. I feel more comfortable about doing that in South Africa. So this over here is President Nelson Mandela, who is beloved by many in South Africa. This was the last president, Professor Zuma. He is loved by far fewer people. This is Siya Kolisi. He is the head of our rugby team. We just made it for the second time into the World Finals. This is the head of the cricket team, captain of the cricket team. He went to jail for crooking the cricket. This is a wonderful band that we have, a wonderful orchestra that made it to the finals of We Got Talent in the States. And this is our electrical utility. We have major problems with power in South Africa, sadly. So these kinds of things going on in your life make you ask some of the big questions. What's it all about, really? For psychiatrists and other clinicians, what's up with psychiatry? And then, as humans, how do I get through today? Now, the phrase problems in living is used by clinicians. It was actually coined by an American psychiatrist, Henry Stack Sullivan, but it was popularized by a critic of psychiatry, Thomas Szasz. Thomas Szasz asked that many people came to see psychiatrists not because they had a mental disorder, but because they had problems in living. He was very skeptical of the notion that mental illness was the same as physical illness. He didn't believe that was possible. He said, if you have a tumor in your brain, then you have a mental illness, but if you have problems in living, then you have problems in living. And that was his perspective, that mental illness was really a myth. Now, the term problems of living really is one that's used in philosophy, as well as philosophy of psychiatry, and you can think about it encompassing big branches of philosophy. The big branches of philosophy include metaphysics, what is out there, epistemology, what do we know, and ethics, what is right. Or as Immanuel Kant, the famous German philosopher, asked, what can I know, what must I do, and what may I hope for? So I've been thinking about this and just wrote this book. And if you apply it to psychiatrists, some of our problems of living include the questions, what is a mental disorder? What causes mental disorders? And then what's the best intervention? As I say, very big questions. Whoops. So I like to think of three different perspectives. The first one is what I call the classical view, potentially begins with Plato, and a modern-day instantiation of that view is that of Robert Spitzer, who wrote the DSM-3. Now, in opposition to the classical view, there is what I would call a critical view. I already talked about Thomas Szasz. He takes a critical view of psychiatry, but probably one of the most famous philosophers of the 20th century is the man on your left, Ludwig Wittgenstein, and over here on your right, a man by the name of Foucault, French philosopher, structuralist, who wrote about madness, again, potentially anti-psychiatry. What I like to do is to try to take the best from the classical point of view, the best from the critical point of view, avoid their weaknesses, and come up with an integrative point of view. And this perspective draws on possibly Aristotle, who was perhaps the father of modern biology and who made wonderful contributions to ethics. And this man on your right goes by the name of Karl Jaspers. He was a German psychiatrist and existential philosopher who made wonderful contributions to both fields. I think sort of in the background here, the title of the talk is Practising Psychiatry with Wisdom, and I suppose that for me, wisdom is about balance. Lots of different cultures talk about this, the Chinese yin and yang, and it's about integration. And I see the integrative position as being balanced and as drawing on the best of other traditions, and so integrating them. So let's get back to diagnosis, and I'll talk about a classical view, a critical view, and an integrative view. So if you're Spitzer, you are trying to think about psychiatric disorders in terms of their operational criteria. He put forward that for depression, it must be 2 weeks, feeling down, more days than not, etc. And so he is drawing on this Platonic idea that you can define a square. The Greeks would have told you has equal sides with right angles. Those are the necessary and sufficient characteristics of a square. In the 20th century, we came up with this thing called the periodic table. Very neat rows, beautiful tables, every element represented, and every element has necessary and sufficient characteristics. Whoops, I'm going too fast again. So, similarly, Bob Spitzer would have said a psychiatric classification reflects empirical work, and each diagnosis should have necessary and sufficient conditions. Now, Foucault would have said, that's complete nonsense. He would have said, think about weeds. Your weed is not my weed. Our definition of weeds changes from time to time and place to place. Our definition of food, what's edible, what's not edible, changes from time to time and place to place. And similarly, mental illness is culture-bound and it's context-bound. And if you're talking about DSM-5 or ICD-11, Foucault would argue that this reflects the spirit of our particular era and its particular power relations. Okay, so I want to argue again to take the best of both of these perspectives. I think the critical view emphasizes that science is a social activity, that it's necessarily theory-bound and value-laden. Science must, because it's being done by humans, reflect human values. Still, as the classical point of view would acknowledge and emphasize, science does discover the structures, the processes, and the mechanisms that are in the world. And so when it comes to psychiatry, of course, our nosology, our classification system is theory-bound. Of course, it's value-laden. But we can talk about those values and we can argue about them and we can debate them in a good way. And part of that debate might be about what are the underlying mechanisms of disease. So let's talk about some of those underlying mechanisms. Let's talk about etiology. And again, I'll go through the classical, critical, and integrative view for you. So a classical view is taken by many of the people that are firm about clinical neuroscience. They say that neuroscience will advance our knowledge of brain components, the neural circuitry, the molecules in the brain. Psychiatric neuroscience will show that all psychiatric disorders are really neurocircuitry conditions or involve particular molecular abnormalities. Now, the critical point of view says that's really not going to happen. In fact, if we look at imaging in psychiatry, there are no brain lesions, no brain lesions in mental disorders. The Enigma collaboration has shown that there are common signatures across diagnoses. There's lower hippocampus in a range of different disorders. And you particularly see that in modern-day neurogenetics, where the Brain Consortium, the Psychiatric Genetics Consortium, have showed that there's significant overlap in the genetics of bipolar disorder, schizophrenia, depression, anxiety, and so on. Moreover, the critical point of view would argue that this focus on brain circuitry and focus on neurochemistry means that we overlook the social determinants of mental illness, which are so very important. Oh, this is a picture from Enigma, actually. And here's the hippocampus that I was telling you about, that it cuts across different disorders. There might be some specificity you could counter-argue, but still, it's much fuzzier. It's certainly not the periodic table that you might be expecting. And here are the genetics. Massive overlap between MDD and anxiety. Massive overlap between schizophrenia and bipolar disorder. And overlap throughout, actually. So again, a very fuzzy picture. Again, very far from the periodic table. If you drew the periodic table, you wouldn't see overlap between gold and silver, would you? So, can we put this together as an integrative perspective? Well, I think we can all agree that genes and environments, the molecules and the social determinants, interact in very complex ways to influence risk and resilience to the spectrum of mental phenomena. And Jaspers is very famous for having said that when we do psychiatry, we need to investigate both mechanisms and meanings. And he would have also said that we need a range of different explanations. That's a position known as scientific pluralism today within philosophy. So I myself would adhere to these 2 points, and I hope you can agree with me on them. What about treatment? So let's again break it up into these 3 perspectives. According to the NIMH, when you apply for a grant, you should be aiming to understand the neural circuitry and the neurochemistry because we need better targets for mental disorders. According to people like MAD in America and those who contribute to the growing literature on MAD studies, that is all really wrong, and rather we need to target the social determinants of mental suffering, and where we do have an effective approach, the big problem is it's not getting to people. So we need to, rather than develop new targets, make sure that what we have is available around the world. From my perspective, the clinical neuroscience approach has got a lot going for it, not everything going for it. The global mental health approach has got a lot going for it, not everything going for it. I'll say a little bit more about both of those in a moment. But we can use both of them, and what we can do is we can aim for what might be called precision public health. If we really want to affect a lot of people, we want to do global health, public health, but how we do that can be a little more specific than public mental health often is. So this is a paper that a group of us recently published in World Psychiatry, and it talks about paradigm shifts versus incremental integration. The concept of paradigm shifts comes out of philosophy of science. It's Thomas Kuhn, and he argued that we really shift from one perspective to another perspective, and he also argued that these different perspectives are not commensurable. We talk past each other all the time. So it turns out that if you do a quick literature search, you see that people love the idea of a paradigm shift. Everyone is busy calling for a paradigm shift. The clinical neuroscientists call for a paradigm shift. The global mental health people call for a paradigm shift. Evidence-based psychiatrists call for a paradigm shift. Those of us interested in positive psychiatry call for a paradigm shift. So I'm worried about that, and for the following reasons. Let's take clinical neuroscience, which really came out of the NIMH, National Institute of Mental Health in the United States, driven by Tom Insel, and is still being promulgated, if you like, by that group. So there are a couple of problems with the research domain criteria that they have put forward, or the RDoC. For one thing, all of that was said many, many years ago. So Herman van Praag, for example, was a Dutch psychiatrist who in the 1960s said, really what we need to be talking about is serotonergic disorders. There's no such thing as depression or anxiety. It's a bunch of serotonergic disorders. So it's old wine in new bottles, if you like. Another problem with it is that you have a real risk of neuroreductionism, converting everything, including complex social phenomena, complex psychological phenomena, into brain disorders. For another thing, this perspective is often over-optimistic. Tom Insel, in his 2006 article putting forward RDoC, said that within 10 years' time, we will have good information about how all psychiatric disorders are brain disorders. Last year, he wrote a book saying that although he had spent $5 billion per annum at the NIMH, he hadn't been able to do that. What about global mental health? So Turkey, South Africa are upper middle income countries. The majority of the world's people live in lower and middle income countries. So the bulk of the research that my Department of Psychiatry does is on global mental health. And in global mental health, we advocate for people being treated in the community. We advocate for people being treated by non-psychiatrists and non-psychologists, by community health workers, and so on. But there are a number of criticisms of this approach, which I love. I love this approach just like I love clinical neuroscience. But there are some problems. So in America, where there was deinstitutionalization in favor of the idea of community psychiatry, it hasn't panned out that well. What you have is reinstitutionalization with many, many people with severe psychotic disorders being housed in prisons. The idea of global mental health is really, if only people understood mental health disorders better, we could destigmatize them. Much as global mental health has published dozens of papers each year on destigmatization, the average person in the street doesn't believe that mental health disorders are the same as physical disorders. There's a credibility gap. If you go to your local politician and you say, 4 out of 5 people will have developed a mental disorder over the course of their lifetime and we need more money for mental health, they look at you like you're from another planet. And then in countries like ours, Turkey and South Africa, the idea that we should let go of professionalism seems to me a little unwise. The idea that people with a high school education can provide what a doctor or a nurse can provide, although advocated by global mental health, and I understand why it is advocated in under-resourced areas, I also worry deeply about it. As I always tell my own colleagues, when I have my heart attack, I'd like please to be treated at the Mass Gen in Boston. David Osser is in the audience and he'll call up one of his colleagues. What about evidence-based psychiatry? Well, of course we must follow the evidence, but the gap between clinicians and researchers is there for multiple reasons. One of them is that most of the evidence is collected in what we call explanatory trials. That is, trials that are done in tertiary academic centers that bear little or no resemblance to the real world. There are trials in which people with comorbidity are excluded, people with homicidality and suicidality are excluded, people who are homeless are excluded. So in psychiatry, we have very few pragmatic or real-world trials. So when we have a patient that we're seeing in the real world, we actually have very little evidence on which to base our treatment. And particularly when there's little evidence, that's when we need maximum amounts of wisdom. What about positive psychiatry? One of the presidents of the American Psychiatric Association is a firm advocate of positive psychiatry, which draws a lot on this field called positive psychology, which is very valuable in moving away from a focus on negative emotions, which psychiatrists are so keen to talk about a lot, and talks really more about positive things, about our resilience and so forth and so on. But there are a number of problems, even though I love positive psychiatry as well, there are a number of problems with positive psychiatry. A crucial one is that if you tell people to aim for unhappiness, if you tell them to aim for happiness, you're bound to make them unhappy. This is a paradox which philosophers have long talked about, and which makes me very skeptical of positive psychiatry. Another point, this is made beautifully by my colleague Randolph Nesse, who's the father of evolutionary medicine and evolutionary psychiatry. He points out that you need to understand that negative emotions have got significant adaptive value and shouldn't be ignored. There's another point, and this is the one that critical psychiatry people make, which is that you focus on the positive, you ignore the underlying structural issues, the underlying social determinants of suffering to your detriment. So all of these paradigm shifts, I would say to you, anytime anyone tells you they've got a paradigm shift that they're offering you, be very, very careful. Tread very, very warily. Be deeply skeptical. If you look at the paradigm shifts that have been put forward over recent years, RDoC, clinical neuroscience, hasn't really resolved the problems that we have in diagnosis and classification. Public mental health hasn't decreased institutionalization. Evidence-based psychiatry was rolled out in the United Kingdom with psychotherapy provided at low cost throughout the population of the United Kingdom. You might think that it reduced the burden of disease in the United Kingdom. No evidence for that whatsoever. That's a little bit different from other kinds of conditions. If you gave everyone excellent treatment for their heart disease, and prevention of heart disease, you probably see a decrease in the burden of heart disease. Not so in mental health, which is extremely worrying. And positive psychiatry, as I've argued, seems less wise than what might be called a negative pathway to flourishing. Okay, so I'm going to then close up with some brief recommendations, aspiring to wisdom. I'll talk about diagnosis, causality, and treatment. So let's talk about diagnosis first. One thing I'd like to point out, I was in a lecture by Robin Murray, who said that we should be careful about adopting DSM-5 in Turkey. I'm not so sure I'd go that far, but I would say that ICD-11 is an excellent document. ICD-11 provides a very useful foundation for nosological science, for classification science. Furthermore, there are some exciting developments at the overlap of epidemiology and nosology. So initially it's true that Bob Spitzer dreamt up the criteria sitting around a smoke-filled room with other men developing DSM-3. But it's now become a worldwide kind of effort. It's deeply scientific, and some of that science draws on epidemiological evidence. So, for example, with anxiety disorders, we can go back at ICD-11 and can say, look, the epidemiology showed us that this criterion is less useful than that criterion. And so I think that DSM-5 is a definite improvement on DSM-4, and I think ICD-11 is particularly good. And I think the anxiety disorders, because I worked on them, are exemplify that kind of improvement. So ICD-11, one of the advances of it is that it focuses on clinical utility in places like Turkey and Africa. Of course, you have to have diagnostic validity, but in addition to diagnostic validity, you need clinical utility. And that is really emphasized in ICD-11. So whereas DSM-5 got stuck on personality disorders and were unable to make any progress whatsoever, ICD-11 has got a very nice dimensional model of personality disorder. I think the other thing that ICD-11 does very nicely is it avoids pseudo-precision. So, I tell the story of listening to the radio recently, and they asked one of my South African colleagues, a psychiatrist, what is depression? And he responded, well, depression is a mental disorder characterized by 2 weeks of symptoms with depression more days than not, etc. This is not what depression is. It's pseudo-specific. And ICD-11 doesn't do that. ICD-11 says several weeks or several months and so on. And that partly addresses the credibility gap. The other thing that ICD-11 does very nicely is you can code a specific disorder in multiple areas. So DSM-5, Tourette's disorder, which is very, very close to OCD, is classified as a neurodevelopmental disorder for reasons that escape me completely. In ICD-11, Tourette's disorder is classified as a neurodevelopmental disorder, as an obsessive-compulsive disorder, and as a neurological disorder. And of course, it is. It's all three. And whereas DSM-5 was tested in a few sites in the United States and had horribly low reliability stats, terrible kappas, ICD-11 was rigorously tested around the world. But there's still some cautions about ICD-11. For one, the validity of specific diagnoses is probably not that high, and primary care clinicians are not that aware of the conditions, and we need to educate them. So there's this notion in philosophy going back to Aristotle of practical wisdom, and I just want to say a couple of things. First of all, it is important, I think, not to medicalize problems of daily living. Burnout is not necessarily a disorder, although it does have a code in ICD-11, but not as a disorder. At the same time, it's important not to underestimate emerging mental health problems. So it was interesting because psychiatrists in the United States have been criticized so heavily for medicalizing everyday life. DSM-5 decided not to have gaming disorder in the classification. It decided not to have compulsive sexual behavioral disorder in the classification. Whereas ICD-11 said, you know what, these are public mental health problems, let's put them in. And I think that was the right decision. And then finally, Mario Mai, the editor of World Psychiatry, has put forward this notion that it's all very well to have a diagnosis, but what we really need to do is to standardize our evaluation of different psychiatric conditions. And he commissioned a bunch of papers on how to do this, one on depression, one on psychosis, et cetera, This is the one on anxiety disorders. So it says, look, once you've got the diagnosis, these are the other things you need to think about, and that will help you in personalizing management. Okay, what about etiology? So I of course, agree with the idea that social determinants, poverty, food insecurity, trauma, play a crucial role in the etiology of mental disorders. But we have to also believe that, or accept that, acknowledge that psychiatry is a medical field, and we think of etiology in complex ways, ranging from the biological through to the psychological and onto the social. So as medical physicians and as psychologists, as allied health professionals, we must steer between neuroreductionism, everything's in the brain, and culturalism, everything's in society. We have to take a middle, wise pathway. So when it comes to etiology then, I think we need to let go of our aspirations about a single cause of disorders. You know, we had syphilis, one cause of multiple disorders. I don't think we're going to see that again. I also don't believe we're going to get biomarkers for many of our disorders. We might get them for autism and Alzheimer's, but I will be blown over with a feather, I could be wrong, I hope I'm wrong, if we have a biomarker for anxiety. And the reason is anxiety is normal. So we're not going to have a biomarker anytime soon. I would say there's a lot of scope for integrating global mental health and neuroscience. Here's an article that appeared on the potential synergies between global mental health and neuroscience. And I think we need much more sophisticated approaches to understanding causality. And the statisticians are developing new tools all the time for understanding polycausality. And then finally moving to treatment. Of course, we need to emphasize access and affordability. But the point I made about earlier that we need to be wary about saying that we can be replaced by community health workers, I think is problematic. We can't be replaced by community health workers, and particularly in low and middle income countries, we need much more specialization. We need addiction psychiatrists, neuropsychiatrists, consultation liaison psychiatrists, and so forth and so on. So I think then when it comes to treatment, we need to draw on consultation liaison psychiatry to foster collaborative care, which is the most evidence-based way of providing care in primary care. I think we need more complex psychotherapy models than we currently have. I'm a big proponent of schema therapy. We need to close the clinician researcher gap. Perhaps big data will help us, perhaps it won't. So what's it all about really? What's up with psychiatry? How do I get through today? I'm not entirely clear, but I would say that psychiatry necessarily rests on philosophical foundations, and it's important to make those philosophical foundations explicit. And then I would say we need to be very aware of complexity. When we talk about these reductionistic paradigm shifts, we need to be aware that they have significant limitations. And then finally, practicing psychiatry with wisdom requires balance, integration, and if we ever achieve that, then we can take some pride in that. Thank you very much for your attention.